Hey, this is Dr. Ben Weitz, host of the Rational Wellness Podcast. I talk to the leading health and nutrition experts and researchers in the field to bring you the latest in cutting-edge health information. Subscribe to the Rational Wellness Podcast for weekly updates. And to learn more, check out my website, drweitz.com. Thanks for joining me, and let's jump into the podcast. Hello, Rational Wellness Podcasters. Our topic for today is hydrogen sulfide SIBO and SIFO and difficult SIBO cases with Dr. Preet Khangura. Dr. Preet Khangura is a naturopathic physician with an integrative and functional medicine practice at Juniper Family Health in Victoria, British Columbia in Canada. Dr. Khangura has a practice focus on treating gastrointestinal conditions, including SIBO, which is the main cause of IBS. Dr. Khangura has also been educating doctors about SIBO at in-person and now with COVID at online conferences. My goal for this interview with Dr. Khangura is to gain some insights into treating some of the more difficult SIBO cases. And we would like to highlight the diagnosis and treatment of hydrogen sulfide SIBO and small intestinal fungal overgrowth in particular. So thank you so much for joining me, Dr. Khangura.
Oh, my pleasure. Thank you for having me.
That's great. So perhaps you can explain to our listeners how you came to become so interested in SIBO and in functional gut disorders.
Yeah, it's kind of an interesting story. My wife always takes credit for it, of course. But you know what? There's some truth to that. So years ago,
you know what? You're not going to win by denying that.
Yeah, exactly. It's true. So years ago, before I even went to naturopathic medical school, I've been my wife and I've been married for close to 14 years, but we've been, dating for 20 plus. And so in our early 20s, she came down with some very significant gastrointestinal issues and kind of came out of nowhere in such a young age, and her hair started falling out. She was starting to get arthritic joint pains, but it all started with very significant gastrointestinal symptoms. Had to take her to the ER a few times. Of course, they couldn't find anything. Her family doctor was just prescribing her antacids, even though she never had GERD. And so I was talking to one of my friend's mothers.
That's the classic treatment for everything, right?
Yeah, throw a PPI at it. And so I was talking to one of my friend's mothers over a Christmas break one time, and she said that, that sounds like what our daughter dealt with last year. And we saw this great naturopathic doctor that focused on gut health, and that sparked my interest. And so she saw a naturopathic doctor here in BC all those years ago, and within 3 months completely turned her health around. And that really sparked my interest in kind of not just naturopathic medicine, functional medicine, but gut health. And so at that time I was doing my degree in physics, and I was going to go into medical physics, but I totally switched gears, went to naturopathic medical school, and always had a sight on gastrointestinal disorders. And when I started practice, I started really diving into SIBO, even in naturopathic medical school, even today, especially back then. SIBO is not really taught very well in even naturopathic medical schools. And so I had to do a lot of it myself, but I dove right into it and really focused on it since day one of practice. And as you know, whatever we practice more of, and that's why it's called practice, we get better at.
Right.
Yeah.
And of course, SIBO is one of those conditions that on the one hand seems like a really simple condition. Mm-hmm. And we do have our cases where everything fits. They have the symptoms. You get the breath test back. You do your normal treatment, whether it be antimicrobials from the natural world or Rifaximin or whatever. And and then they resolve and end of story. And then we have our 50% or so of cases that don't seem to come along so easily.
Yeah, exactly. That's exactly it. And that's what I see a ton of that in my practice, because I do have the expertise in SIBO and other GI disorders, dysbiosis disorders especially. I get a lot of these very stubborn cases referred to me. So I'd say in my practice, more than 50% are the stubborn cases, but that's where you really learn as a practitioner. And that's what I try to get across in my courses and seminars for other doctors is like, keep your fingers crossed that you get a really easy case, because it's good for you and the patient, of course. Right. But But really, where you're really going to learn, especially the individualistic treatments for patients, as opposed to just like protocols or blueprints, are those patients where they've already tried this, and the SIBO is not resolving, or it's coming back quickly, or whatever it may be.
Right. So I heard you say that IBS is a lazy diagnosis. What did you mean by this?
Yeah, so that ruffles a lot of feathers in with some of my, especially more just MD colleagues, but
conventional GI docs.
Conventional GI docs, yeah, and really what I mean by that is kind of tongue in cheek, because obviously it is a diagnosis. However, it's more of a label than a diagnosis. Kind of like fibromyalgia as a label, chronic fatigue syndrome is a label. There's obviously always root causes to these conditions, and digging deeper to find out that root cause, then you can actually treat that as your therapeutic target, and actually not just mask signs and symptoms, but actually resolve the case, hopefully, for these patients. And so the problem is, and I'm sure you know this yourself, is when the patients get that label of IBS, so many times that's where the doctor stops and says, and they use the word just quite often. They'll say, you just have IBS. Right. You're just going to have to deal with it. You're just going to have to take laxatives. You're just going to have to take a PPI.
Yeah, well, partially it's a diagnosis of exclusion. They've excluded IBD, their scope is negative, there's no parasite. So it's just this functional gut disorder.
Yeah, exactly. And it ends up becoming a lazy diagnosis because those doctors will kind of stop at that point and just give maybe some dietary recommendations. Now, a lot of doctors are recommending the low FODMAP diet and other things. But that's really the extent they get, other than, maybe, things to slow down the diarrhea or slow down the cramping or whatever it might be. And so that's basically why I'd call it a lazy diagnosis. And SIBO, by no means is SIBO always the root cause of someone's IBS. It's definitely near the top of the list for a lot of the patients. But of course, there are cases of quote unquote IBS that SIBO is not the root cause, but definitely SIBO should be there on the practitioner's DDX.
Well, what are some of the other causes of IBS besides SIBO?
So one that mimics SIBO extremely well, definitely a lot more rare than SIBO, it would be something like pancreatic insufficiency. So this would be a condition where the patient's pancreas is not producing enough of the digestive enzymes like lipase, proteases, and amylase. And
how often do you think that happens?
I couldn't really give you a number, but I have seen it a decent amount in my practice, whether I suspected it, and so I prescribed actual prescription strength enzymes to see if it made a significant difference, or we ran a stool elastase test, which is very diagnostic of pancreatic insufficiency if the number comes back lower than usually a threshold of 200. Depends on what units they're using. But actually,
I recently spoke to Dr. Steven Sandberg Lewis. And even though the labs usually give 200 as a cutoff point, he feels that really a normal elastase should be over 500.
Yeah, exactly. And so in that kind of gray zone, if a patient comes back with 300, I'll still usually prescribe the enzymes just in case, because the reason why it's a perfect mimicker of SIBO is because really when you boil down SIBO, you can get into all the pathophysiology, you can get into all the, the details, the nitty gritty details of why we develop it, what happens, what bacteria are there. But really what it comes down to is over fermentation from an overpooling of bacteria in the small intestines. Now, pancreatic insufficiency, even if a patient does not have SIBO, so they have a regular amount of tiny amount of bacteria in the small intestines, but if they now don't produce enough enzymes to break their proteins, carbs, and fats down properly, the meals they're eating are just sitting there in their small intestines much longer than they should be. And even that small regular amount of bacteria can now over ferment the fibers and sugars that came in that meal because it's just sitting there. And they can produce SIBO-like levels of gases, even though the actual community count isn't at an overgrowth level. So that's one that I'd say is almost a perfect mimicker of SIBO. And you'll sometimes hear that, okay, if someone has pancreatic insufficiency, they definitely are going to have diarrhea because of the fact that the food's not breaking down well, fats aren't breaking down well, so the gut will just send things out. And we do see that very often, IBS-D caused by pancreatic insufficiency. But I've had many constipation cases where pancreatic insufficiency actually was the big root cause. So those are things also to watch out for, is that it doesn't always have diarrhea.
Yeah, I found that some of the constipation cases are some of the most challenging of cases, and they often don't fit, the classic. They don't have elevated methane. And a lot of times getting rid of that constipation seems to be a really, really tough.
Yeah, they probably are the most stubborn cases to crack. And I find when we talk about methane, so, there is that big connection between methane production in the small intestines and slowing of the colon motility, leading to constipation. And I think the reason why they can be the toughest cases to crack is that if you do not resolve the constipation aspect, it can be very difficult to have the patient feel better, even as you're getting rid of, let's say, their SIBO, their hydrogenic SIBO, or hydrogen sulfide SIBO. Because if the colon motility is not very good and they're not evacuating their bowels very well, they are going to just have higher levels of discomfort, gas, bloating, just not feeling well, low appetite. And so until you can resolve that constipation, and if that means eradicating enough of methane bacteria to do that, okay, great. But the problem is, as you probably know, a lot of your listeners may know, is that there's methane producing SIBO, and then there's something called methane induced constipation. And these can be two separate things. Obviously, if someone has methane SIBO, they have an overgrowth of methane bacteria that could very easily lead to constipation. Not always, because it depends on what else is going on. But there's some patients that have what's called methane-induced constipation, where they don't actually need a full overgrowth of the methane bacteria colony. They're just the unfortunate subset of patients where they just need a small amount of methane production to cause their constipation. And, you as a practitioner, any other practitioners out there may see this on SIBO breath tests, where they say, okay, the cutoff for methane-producing SIBO is between 10 to 12 parts per million of methane. But then sometimes you'll see this little fine print saying, but some practitioners consider 3 parts per million a positive diagnosis, but they don't tell you positive diagnosis for what. Really what they're trying to say is some patients, if they have constipation and they have at least 3 parts per million of methane, there can be a big correlation. So those patients can be really tough.
When we see those recommendations for how these tests should be interpreted, like the North American consensus, that's a consensus of different doctors that had to all agree. And I've spoken to Dr. Pimentel before, and he had recommended a cutoff of 3. But the consensus was 10.
Yeah, that's exactly it. And that's something that I brought up in a lecture I did this past summer on breath analysis, and really what the real data shows, and how this consensus was just, decided by a group of docs and based on some research, but the research is quite flawed in some ways. And I do agree with Dr. Pimentel with the whole 3 parts per million aspect, because I've had many patients where we had to eradicate virtually all of the methane bacteria in that small intestinal tract before that constipation resolved. And until we could do that, the patient was getting some benefit in a lot of these cases, because we were getting rid of maybe some other problems, hydrogenic SIBO, whatever else. But because they were not able to move their bowels properly until we were able to eradicate enough of the methane bacteria, archaea technically, then these sometimes can be the tougher cases. And what I also will mention to practitioners is that if you have a patient that has methane-induced constipation, where you need to get their methane levels down to below 3 parts per million, these are also cases that their constipation will very likely relapse very easily, because it won't, even if you have them on a good prokinetic and you're doing all these good things. And the reason being is that it won't take much overpooling or repooling of methane archaea again to get back to 3 parts per million, and all of a sudden they get constipated again. So even if you're able to resolve in those cases, you got to be on top of even prophylactic treatments and good prevention.
Well, what are your favorite prophylactic, or what are your favorite treatments for breaking the constipation cycle until you eradicate the methane?
Well, so the way I look at it is, if I do suspect that the methane growth and methane production is the cause of the constipation, eradicating that growth is the treatment that I go with. So, of course, you could do things like some prokinetics that can help colon motility, like prucalopride, for example, and you can get their bowels moving kind of in a sense artificially, because you're inducing the contractions, or even other over-the-counter laxatives or high-dose magnesium, Senna, whatever it might be. But that's not getting to the root cause. So the way I look at it is, if a patient needs to be on something as we begin treatment, just to get their bowels moving. Otherwise, they'll be only going twice a week or something like that. Then I'm fine with them remaining on something like that at the beginning. But my goal is to eradicate the methane archaea to a point where they don't have to be on those laxatives anymore. They don't need the actual prokinetic to have a bowel movement. That's where there's a lot of confusion on what a prokinetic is for. It's really for retraining the migrating motor complex contractions as opposed to making sure patients have bowel movements. So that's the way I look at it is, and so if that means using pharmaceutical antibiotics, if that means using specific herbal extracts to kill the methane archaea, elemental diet, then, picking the right agents in that scenario.
What are your favorite herbal agents for killing the methane?
For the methane, so I have this one tincture. I just call it my Sibo Tincture. A lot of these docs here in Canada, they know it by the name Tincture of Death. And it goes back to a story of one of the first patients I gave it to. I asked him, how'd the tincture, because the tincture had a really strong taste. I go, how do you handle the tincture? And he goes, you mean the tincture of death? And I chuckled in. I go, what do you mean by that? And he goes, well, it obviously worked at killing the bacteria because I'm feeling better, but it also tasted like death. And I'm like, okay. So, but basically I just call it my Sibo Tincture. Calling it tincture of death is a great marketing ploy. So, but basically this is personally what I've used. A lot of docs that I've taught use it, but it's a very concentrated combination of the three herbs, golden seal, myrrh, and thyme. And some docs do equal parts. I do a little bit more of the golden seal myrrh than the thyme in the tincture. But that tincture I've seen work over and over for methane overgrowth, but also it can help with hydrogenic overgrowth. Probably not the best choice for hydrogen sulfide overgrowth, which we can get into in a little bit. But that tincture I use quite often. Allicin extract can be good. I specifically use a product called Alamax. A lot of docs know about that one.
Yeah, we use the same one.
Yeah, so that one can work well in some cases. You'll hear that oregano is better for hydrogenic SIBO. It's definitely not black and white. I've seen oregano, you work well for methane overgrowth, and there's a very specific emulsified oregano that I use called ADP emulsified oregano from Biotics Research.
Right.
That's a good one. I've seen that work well. And then, of course, there's other good formulas that can work. The Candibactin AR, Candibactin BR products.
Yep.
Yeah, when using combo, they can work. And so there's a lot of options. Definitely the methane archaea will be tougher than the hydrogenic bacteria. But if you use kind of the right agents, then, you can you can hit them pretty good. Now, the caveat to all of this is whether it's hydrogenic, hydrogen sulfide, or methane producing SIBO. And I talk a lot about this when I do my courses is biofilm production. So bacterial biofilm is, in my opinion, the number one reason why we see a lot of those very stubborn SIBO cases out there where you can't even start an eradication. You even give them rifaximin and neomycin, rifaximin, metronidazole. You give them all these herbs, but the SIBO is just not budging. You retest, the numbers aren't getting better. They're even maybe getting worse. Bacterial biofilm is definitely a big problem in a lot of these cases. So a good biofilm disruptor, no matter what you pick to kill the bacteria, a good biofilm disrupting agent is key for a lot of these cases.
What are the best biofilm disruptors?
So there's some very simple kind of single ingredient things you can use, but by far the best biofilm disrupting complex would be what's called a bismuth thiol complex. So bismuth, like, the bismuth that's in Pepto-Bismol, but it's a little bit different version of it. It's bismuth subnitrate as opposed to bismuth salicylate. But the bismuth thiol complex is bismuth subnitrate mixed together with either DMPS or DMSA, one or the other, and also alpha lipoic acid. ALA.
This is something that's compounded?
This is something that has to be compounded. And so, here in Canada, there's a couple pharmacies that do compound it for clinicians. And I know in the States, there's some pharmacies that do a lot of this product as well. And this product has had some good research on it, showing that there's two different forms of biofilm. There's phase 1 biofilm, there's phase 2 biofilm. And there's a lot of agents that can work on phase 1 biofilm, especially a lot of natural agents. But once the biofilm gets to phase 2, and essentially what that means is it's very much matured biofilm. So it's been been getting produced for many years, at least many months. And there's significant amounts of metalloid links within the biofilm. You need something better than what can open up the phase 1 biofilm. That's where the bismuth thiol complex comes in. When the compounding pharmacy mixes these 3 ingredients together in the right ratio, the ALA and the DMPS will bind tightly to the bismuth subnitrate, and this will form one whole new agent. So it's not like taking 3 separate, really awesome biofilm disruptors. They're actually all very mediocre at opening up biofilm. But when they combine and form this one whole new agent, in an analogy sense, it forms like a wedge that opens up the metalloid links. And it's been shown to open up phase 2 biofilm, at least at this point, probably the best compared to anything else. But if you weren't going to use that, or you couldn't use it, then something as simple as N-acetylcysteine, NAC, can work very, very well. Very good research on that with inhibiting biofilm production and also opening up biofilm. There will be cases where it fails if it's significant phase 2 biofilm.
What dosage you like for the NAC?
So I typically will do a little bit higher dose than we normally do for NAC. So 1,000 milligrams twice a day, empty stomach. And empty stomach for any of these disruptors is important to get to the gut biofilm, including the bismuth thiol complex. You want to do empty stomach. A lot of people talk about enzymes, like they'll do enzyme formulas to open up biofilm. They're pretty weak at actually opening up biofilm. They're more so for more prevention, so they can inhibit biofilm production by the microorganisms. So a lot of cases, especially my cases that have been pretty tough to crack, or I do see we can solve it, but there is a relapse rate that happens. A lot of times I'll put patients on these enzyme formulas or lower dose NAC long-term after we actually resolve the case, just to inhibit more biofilm production as time goes along.
Which is your favorite enzyme formula?
So if I was going to use an enzyme formula, I don't use it often because I'll typically prescribe the bismuth thiol complex. But there's, I'm forgetting the actual name of the product now, but it's made by the company Claire Labs.
Yeah. Interface Plus. Yeah. So that's probably one of the better ones. And then here in Canada, there's one called Biofilm X by VitaAid, which is a fairly similar formula to that one. But like I said, if I had to choose, I would, and I wasn't using the bismuth thiol complex, right, I would still pick high dose NAC over the enzyme formulas. Yeah. And then I think Paul Anderson developed a bismuth thiol product that just doesn't have the DMPS or DMSA.
That's exactly, yeah. So thanks for bringing that up, because I was going to say that an alternative, if you're a practitioner that can't, let's say, prescribe the DMPS or DMSA,
right.
Paul did formulate for the company Priority 1. Right. And it's a product called Phase 2 Biofilm, which has the bismuth subnitrate, which is just over the counter, and then alpha lipoic acid, and then black cumin seed. The black cumin seed will bind to the bismuth in a similar way as the DMPS, but just not as tightly and as strong. So, but it's a very good alternative formula. Yeah.
Okay. And you use that for which forms of SIBO, or all of them?
Pretty much all of them. Because all microorganisms are virtually all microorganisms produce biofilm directly, including fungal species, Candida species. They produce a lot of biofilm when they co-colonize with certain bacterial species. And so I'll use a biofilm disruptor pretty much with every SIBO case. Now, not all SIBO cases need it, but I like to hedge my bets, because if I do a very well-rounded treatment on a patient and 2-3 weeks later, they tell me they've had zero resolution of any symptoms, zero improvement at all, then the next step would be, well, we probably should have done that with biofilm disruptors. Let's try again. And I'd rather not do that. So I'll do the biofilm disruption along with the eradication agents. Some cases, what I'll do is, especially if it's a case that comes to me and I see in their history they've already tried everything under the sun for their SIBO, and their SIBO is very much there still, I'll do very good biofilm disruption like bismuth thiol complex all by itself for a set period of time before we even go back to eradication, because there's going to be some cases out there that need extensive biofilm disruption before anything's going to work. And I have cases where 3-4 months of biofilm disruption, and then we go back to something they've already tried, and all of a sudden they get full resolution.
Yeah. How did you decide that 3 or 4 months was the right amount of time?
Yeah, good question. So for some of these cases, I'll have them stay on the biofilm disruptor until they get a flare-up of symptoms. And Paul teaches a lot about this as well. And basically what happens is when biofilm is produced and these colonies are living within it, it actually can inhibit how bad that patient's SIBO symptoms are. Because what happens is the colonies are living within the biofilm, and then when that patient eats, only some of the SIBO comes out of the biofilm to feed. The rest stays behind dormant and protected in the biofilm. So it actually limits how bad the fermentation can be. So when you put a patient on just biofilm disruption, a lot of times I'll tell them, you're going to stay on this until you get an unexplained flare-up of your symptoms. And a lot of these patients, they don't believe me because their symptoms are already quite significant. So like, how could it get worse? And it does. When this biofilm opens up, all of a sudden there's two things that happen. One is the actual colonies, the overgrowth actually become more active. So they're going to ferment more. You're going to give you more symptoms. But the other thing that happens is that the gut's immune system can now activate against the overgrowth, because that's one major reason why bacteria produce biofilm isn't just to adhere to a surface. It's to protect themselves from your immune system, from the environment, whatever else is out there. So for two reasons, the patient might get a flare-up. Gut's immune system activates, the actual overgrowth gets more active. And I tell them, we're looking for an unexplained flare-up. So it's not because you change your diet. It's not because you're getting sick. It's, you're just doing your everyday old thing. And all of a sudden for the last 2 or 3 days, you thought your bloating was a 10 out of 10. It's a 12 out of 10 now. Diarrhea has increased. Constipation has got worse, whatever it might be. And that's when I'll add in the eradication agents. And so when I talk about those cases that took 3 or 4 months, those are cases where the patient had enough patience to stick with that protocol until they got that flare up. And it can be tough. I don't lie. I don't lie about that, because the patients are like, okay, I've been doing this for a very long time. I haven't got that flare up. You told me it's coming. And so sometimes, practitioners will start the eradication before that flare up. And sometimes it still works because the flare up isn't always distinct, but it can be very distinct, and it's a good hallmark. Hallmark. So, it's time to start the actual eradication.
So for eradication agents, Rifaximin we know is 10 days or 2 weeks. But what about when you use herbal agents? What length of time do you usually prescribe them for?
So regardless if I prescribe pharmaceuticals or herbal agents, I'll prescribe about 2 weeks worth at a time. Now, some cases I'll do up to 4 weeks because we already have a history, you already kind of had an idea that this body will take more than 2 weeks. And I know that the patient is okay with these agents. There's no side effects I'm worried about or anything like that. But in general, I'll break down treatments into 2-week chunks, because the way I look at it is if a SIBO treatment is working, like actually working at a significant level, even if it doesn't completely resolve someone's SIBO case in 2 weeks, which is very common that it doesn't, you want to still see at least moderate to good improvement with that treatment protocol you have set. So, because I know a lot of practitioners will give a patient like 6 weeks of the same combo of herbs and then say, we'll chat in 6 weeks. Then they find out in 6 weeks, oh, that did nothing in those 6 weeks. And so it was a waste of time, also a waste of the patient's money, because if that combo was going to work, they should see some improvements within the first couple of weeks. It may only be 20, 30%, or it might be 80, 90%, or anything in between, but you want to see some improvement. So I'll still kind of prescribe in that manner and then kind of go from there. But there are cases where I do prescribe for longer. When it comes to the pharmaceuticals, typically it is at maximum 2 weeks at once. Like herbs, sometimes I'll go longer, 2 weeks. Rifaximin is very, very safe in general when it comes to antibiotics. So if you were going to do an antibiotic for more than 2 weeks at a time, that would be the one that I wouldn't be too worried about at all. It doesn't absorb. It's pretty much inactive in the large intestine, so it doesn't eradicate where you want to keep bacteria. But those other antibiotics, neomycin, metronidazole, amoxiclav, trimethoprim sulfa, all those other ones, definitely I wouldn't prescribe more than 2 weeks at once. And you just want to make sure, you're doing more good than harm, of course.
And do you recommend specific dietary changes at the same time as the eradication process?
So my recommendation is not to do a strict anti-SIBO diet, not to do a strict low FODMAP diet, biphasic diet, whatever anti-SIBO diet that the practitioner uses. And Dr. Pimentel talks about this a good amount as well, and it actually has to do with biofilm. So if you do a very strict anti-SIBO diet, however you classify it, what can happen is the bacteria can produce potentially more biofilm because you're not feeding them as much. So they start to produce more biofilm, they start to go more dormant. And, there's that research that a lot of people kind of cite and quote about rifaximin with Gower gum. and showing that Rifaximin works better if you give Gower gum with it. Essentially, what the research was showing.
I think in the U.S. they call it guar gum, hydrolyzed guar gum.
Yeah, guar, tomato. But basically, what the research really is showing is that if you bring the bacteria out to feed by giving that gum, the rifaximin will hit the bacteria better. And so,
well, I think that's the main reason why Dr. Pimentel actually recommends not restricting the diet, is because antibiotics work by acting on the replication, act on the cell walls during replication. And if the bacteria are happily fed, then they're going to be reproducing, and so it'll be more effective. But we don't know that herbs are going to work the same way. In fact, we don't think that they do. So
no, and they might not. But the way I look at it though is I still don't. There's another reason why I don't have patients do one of those strict anti-SIBO diets, especially if the patient's never done it before. Like if they come to me saying, "Oh, I've been doing like a low FODMAP diet for 3 months straight, and it helps reduce my symptoms by 50%." Okay, we have that benchmark. We know what that diet's doing.
Okay.
We then know if they only get better with the antimicrobials, that they are actually doing something. Whereas if a patient's never done that diet before and I'm starting them on eradication, and I say, okay, you know what, you're also going to do a low FODMAP diet. Then in 2 weeks, they tell me they're 50% better. At that point, I don't know how much is because they're not feeding the bacteria or how much of it is because the eradication is working. Then you just have to figure that out. I'd rather not do that. And the thing is, feeding the back, and it's not like I tell patients or Dr. Pimentel tells patients to do the opposite of a low FODMAP diet, right? Like just go nuts on high FODMAPs. The patient's not going to feel well if you do. Right. So it's really about just having some fermentable fibers or sugars in those meals, that they, especially the ones they take the antibiotics with, or even the herbal antimicrobials, just to cover your basis. Just enough so that this can potentially help. And if they only get better with antimicrobials and you've done nothing to the diet, then you know the antimicrobials are very likely the reason for that. So there's actual eradication occurring. So that's the other reason why. But there's certain things I still tell them not to do. So for example, because there's a controversy over probiotics and SIBO. And what I will say is it's not black and white, but what I do see is that most patients with SIBO will do worse with broad spectrum probiotics. Not always the case, but
Dr. Ruscio's a huge fan of using probiotics as first line for SIBO.
Yeah. And that's one place I think we disagree on. And really what it comes down to is we can all have theories on it, but it also is patient experience. And so a lot of my patients, when I ask about, do probiotics make you feel better, no different, worse? And this is before I've even mentioned the word SIBO to patients, and this patient may not even know what SIBO is. So many patients that have SIBO will actually say, that's interesting you say that, because all I'm told is to take probiotics and I get worse when I take them. And this is the dietary thing I tell them not to do is, or I'll drink kombucha and I'll feel horrible. Or I start eating sauerkraut every day and I just got worse and worse, which are just probiotic foods. So those type of foods, I will tell SIBO patients to actually, if they are eating them, to limit them or completely eliminate, because if taking a probiotic is actually making their SIBO worse, then we got to eliminate those probiotic foods, at least while you're trying to deal with the SIBO. Doesn't mean they have to eliminate them forever, but at least at that point, because it's counterproductive otherwise. Now, the reason why, probiotics may make SIBO worse, it all comes down to the root cause of developing SIBO. And it's not the same for everybody, but the majority of SIBO patients is because their migrating motor complex or their phase 3 contractions of their migrating motor complex have become weakened. And so therefore, AKA the sweeping action of the small intestines. So if they're putting a bunch of oral bacteria in through the oral route, and they're not being forced into the large intestine where they're supposed to go, and they're just pooling in the small intestines, they're still fermenters. They're still gas producers. They've done aspirate studies on SIBO patients and found, one study quite a few years ago found that 25% of the SIBO patients had lactobacillus overgrowing. They're still hydrogen producers. And so that's where I lay, that's the side I'm on when it comes to probiotics and SIBO. Bifido species, I'm not so worried about, because bifido species, they've never really been implicated in causing SIBO, like in aspirate studies. So they don't seem to be the species that overpools. And the one theory on why that is that they don't really survive well in the small intestines, whereas lactobacillus species do. of that kind of 1% of bacteria that's supposed to live in the small intestines is supposed to mainly be lactobacillus. So if they are not forced out, they can survive there. Whereas like a bifido only probiotic, which there's now more on the market as like quote unquote SIBO, okay probiotics. I don't see as much trouble with them, but with lactobacillus, with probiotic foods, I do see, quite a few patients have issues with them. So
we've had good luck recommending spore-based probiotics with simple patients.
Yeah, and that's another one that I think I've seen less issues with. I don't use a lot of the spore-based probiotics in my practice, but not for any like real reason or anything like that. I just haven't really included in my practice too much. But that is something I've seen with patients that, once again, when they mention, spore-based probiotics aren't so bad, but this other probiotic is,
in particular, the Megaspore product is we found to be really helpful.
Mm-hmm.
So let's get into hydrogen sulfide.
Sure.
So how do we, so far we've been diagnosing hydrogen sulfide SIBO by patients who have IBS SIBO symptoms, and we do the breath test, and they have essentially a flat line. We see no significant increase in hydrogen or methane.
Mm-hmm.
Of course, now Dr. Pimentel has finally come out with the new breath test, the Trio, that also includes not only methane and hydrogen, but also hydrogen sulfide, which I haven't used yet, but I just got a couple of kits.
Mm-hmm. Yeah. So the flatline test results on just a hydrogen methane breath test can indicate hydrogen sulfide SIBO. Not always, but it can. But the other thing I think that that really needs to be known, and this is something I really focused on in that lecture I gave in the summer when it came to SIBO breath test, is that, and I see this in practice all the time, is that when someone has hydrogen sulfide SIBO, they can still have regular looking SIBO test results. So like spikes of hydrogen or elevated methane and hydrogen, or elevated methane causing hydrogen flatline. All these are still in the realm of possibility. So if a patient has hydrogen sulfide SIBO, don't only look for the flat lines. And I think that's where we're going to get a lot of value out of the new Trio Smart test, is that, well, now a lot of practitioners are going to see that, oh, wow, this patient actually does have a hydrogen spike and they have hydrogen sulfide SIBO. So if I was only looking for the flat line, I would have missed the hydrogen sulfide SIBO aspect. So that's why I always teach about, don't just go based on flat lines, go based on medical history and hallmark symptoms of hydrogen sulfide SIBO. And a lot of us know a couple of those hallmark symptoms. One can be, chronic, very pungent, rotten egg smelling gas. Not just once in a while, but it's always there. Obviously that smell is produced by hydrogen sulfide gas. But another symptom that can happen is unexplained halitosis, so unexplained bad breath. If their hydrogen sulfide overgrowth is high enough in the small intestines, that hydrogen sulfide gas will come up into the stomach, up the esophagus, and cause unexplained bad breath. And we know that these can be hallmarks of hydrogen sulfide SIBO because when you treat the hydrogen sulfide SIBO very specifically with specific agents, which we can get to in a few minutes, all of a sudden that bad breath starts to go away. The pungent smell goes away. So you can also use that as an indicator of your treatment, even if you aren't using the Trio Smart breath test. So for example, here in Canada, the Trio Smart still is not available in Canada just yet. They're hoping to get it available here, hopefully by early mid next year. But up until that point, if you're not using the Trio Smart test, looking for those couple hallmark symptoms, but there are other things to look for. So for example, a lot of us know that high FODMAPs or fermentable fiber foods and fermentable sugars will trigger a lot of classic SIBO symptoms. But hydrogen sulfide bacteria, I call them hyperfermenters because they don't just feed on fibers, they don't just feed on sugars, they also are sulfate reducing bacteria. And so foods rich in sulfur compounds will also trigger a lot of the symptoms. And so, of course, garlic and onions are sulfur-containing foods, but anyone with SIBO, garlic and onions could cause symptoms. So what I ask a lot of patients when I'm trying to figure out if there's hydrogen sulfide SIBO is I'll ask them, have they ever noticed just eating eggs causes the same bloating or the same gas smell or cramping, diarrhea? Does eating just red meat do the same thing? Or if they haven't tested just eating red meat, go ahead and just have a steak and tell me what happens. And it's because the sulfur compounds in those foods may still be enough to trigger the hydrogen sulfide symptoms. So things such as that. And then, of course, some medical history stuff as well. Chronic or recurrent UTIs a lot of times can stem from hydrogen sulfide dysbiosis, because most UTIs are hydrogen sulfide producing bacteria. Well water use, that definitely is an easy way to pick up hydrogen sulfide bacteria if they're not using the UV light.
Okay. So what are some of the favorite treatments for hydrogen sulfide SIBO?
So naturally, there's less options than we have against hydrogenic and methanogenic SIBO cases. And a big reason why, and same thing with pharmaceutically, although there's some really good options in both realms. Hydrogen sulfide bacteria are notoriously resistant to a lot of different antimicrobials and antibiotics. And this is why a lot of the hydrogen sulfide bacteria that live in the human gut and propagate in human gut are actually very dysbiotic bacteria. So with hydrogen sulfide...
Do we know what some of the most common bacteria are that produce hydrogen sulfide?
Yeah, so the most common ones and the ones that are most commonly overgrowing, unfortunately, in the human gut would be dysbiotic species such as Klebsiella species, Klebsiella with a K, especially Klebsiella pneumoniae, Proteus species with a P, Citrobacter species with a C. Those three are ones I focus a lot on in my seminars because they don't just cause hydrogen sulfide SIBO. These guys just overgrowing in the colon terrain where we're supposed to have a lot of bacteria. They are very enterotoxic bacteria. They're very much correlated with developing autoimmune conditions, including Crohn's and ulcerative colitis, but even things like rheumatoid arthritis. Proteus and rheumatoid arthritis go hand in hand. Ankylosing spondylitis and Klebsiella go hand in hand. And so they can be bad for us throughout the gut. Now, there are some regular bacteria that produce hydrogen sulfide. E. coli is one, not the food poisoning E. coli, but the regular E. coli is a hydrogen sulfide producer. But majority of the hydrogen sulfide producers in human gut, especially in these gut cases, are the dysbiotic species. Morganella morgani is another species. That's a big time histamine producer as well. So a lot of these histamine cases that docs are seeing, for some of them, it's actually stemming from the gastrointestinal tract. Obviously, Morganella is not the only histamine producer, but it's a big one. But that's another dysbiotic hydrogen sulfide species. And so when you diagnose them with hydrogen sulfide SIBO, just like if you diagnose them with hydrogenic SIBO and you just do it based on a breath test or just based on symptoms, obviously you don't know exactly which species are overgrowing. Some docs will talk about running a stool test and trying to determine that. But the problem with the stool test is that it only tells you what's going on in the colon terrain. It doesn't tell you what's going on higher up. You can maybe use the stool test to say, oh, look at that. There's heavy growths of Klebsiella, heavy growths of, let's say, Proteus. Maybe they're overgrowing higher up as well, but you can't guarantee that. So to treat them, go back to that question, is that because these guys are notoriously resistant, that's why they hang around a lot after heavy antibiotic use. And so that's another history thing for practitioners to ask their patients is, their antibiotic history and did things get much worse after that? And so what I have found that works the best when it comes to pharmaceutical antibiotics, if it's primarily just hydrogen sulfide SIBO, so you only need to get rid of them in the small intestines and they're not overgrowing in the colon, Rifaximin is a pretty good option. Rifaximin does have proven activity against most of these species, but what I've seen work even better than Rifaximin from the pharmaceutical side would be amoxicillin clavulanic acid or sulfatrim, the sulfa-based antibiotic. When one of these works, it works extremely quickly. And so I only typically prescribe a 5 to 7 day course of the amoxiclav or the sulfatrim, because when it's working, the patient should see significant changes in those 5 to 7 days. And if they haven't seen much change in 5 or 7 days, I don't typically continue with the same antibiotic. I'll switch to something else. Now, of course, these antibiotics do come with some side effect risk and things such as that. So if you want to go natural or you can't prescribe the antibiotics, what I find works best for hydrogen sulfide SIBO naturally, I do this combination quite a bit, but it's the herb Uva ursi, which a lot of us know are used for UTIs. And the biggest reason why it's used for UTIs is that most UTIs are caused by hydrogen sulfide producing bacteria. And so Uva ursi is very specific at killing hydrogen sulfide bacteria. And if they're overgrowing in the gut, it will hit them there first. And so I do use a very concentrated version of Uva ursi. I'll use a 1-to-1 or a 1-to-2 tincture, which can be tough to get. Some good herbal pharmacies do carry it, but most of the times in health food stores, you'll find a 1 to 4 or 1 to 5.
Are there any products on the market that are available to practitioners that you could recommend?
We typically just get the tincture from like a good herbal dispenser here in Canada, and there'll be some good herbal tincture, dispensaries and pharmacies in the States. I'm sure that make a 1-to-1 Uversi or 1-to-2. It's easy to get a 1 to 4, 1 to 5, like at a health food store, but the patient would have to take boatloads of it to really work for a hydrogen sulfide SIBO case. And so with for example, a 1 to 2, which is the one I typically use, I'll do about 3.5 to 4 milliliters twice a day with food. So about 7 to 8 milliliters a day. And it does contain hydroquinone, which some, people are worried, that, affect the liver and cause liver damage. And there's always a theory that hydroquinone in Uversi might, but it's never really been solidified. The hydroquinone in Uversi is called arbutin. And yes, I don't prescribe an extensive amount of it. I'll prescribe about 2 weeks at a time, but it's, in my opinion, it's not a big thing to worry about. But if you do the 3.5 to 4 mils of a 1 to 2 for 2 weeks, unless the patient has a history of liver issues and liver disease, I don't think there's much of a problem. So that's one agent I use that can work very specifically for those guys. So if you give someone that Uversi and the patient's getting better, you're specifically treating hydrogen sulfide bacteria, because that's really all it goes after. It doesn't really go after hydrogen or methane bacteria. Now, another product that can be used with Uversi that can work in a lot of cases is silver agents. So, old school colloidal silver is out there, but the newer version of silver called silver hydrosol, which is instead of the silver kind of bound to the water molecule, the silver is part of the water molecule. And the hydrosol version, about 99% is eliminated in 24 hours. And about 100% is eliminated in 48 hours. So it doesn't actually pose the risk of giving the patient blue man syndrome like standard colloidal silver does, because that one, the silver can actually dissociate from the water molecule in the colloidal silver version. Silver hydrosol, it can't do that. But silver is very antibacterial, as I'm sure you know, and hydrogen sulfide bacteria is something it can target. So a lot of times I'll do a silver hydrosol product with the Uversi as a combo kind of natural therapy, or sometimes I'll do one of those with other herbs because the patient has hydrogenic SIBO as well, or they have methane producing SIBO as well. And so, and that's is another tangent, but the thing is as well, is that if someone has one form of SIBO, they usually have, let's put it this way, a patient usually has more than one form of SIBO. Sometimes they might just have hydrogenic SIBO and very low methane and no hydrogen sulfide overgrowth. That does happen. But usually if someone's migraine motor complex isn't working very well, they are going to have an overpooling of bacteria across the board. Not always all three, but usually 2 of the 3. So doing a well-rounded treatment, even if a patient has hydrogen sulfide SIBO, is recommended. But sometimes I'll do a very specific hydrogen sulfide treatment first, just to see what gets better first, and then move on from there.
Okay. So small intestinal fungal overgrowth. So this is something that comes up when we have a patient with IBS SIBO type symptoms and the breath test is negative. And then we ask ourselves, could this person have SIFO? So how do we diagnose that? How often does it happen? And then what do we do about it?
Yeah, so that's always the $1 million question, is how to diagnose SIFO or just fungal dysbiosis in general. SIFO obviously is just a really good, obvious buzz term that's been created because of SIBO. But, it's always been that, whatever you want to call it, yeast overgrowth, candida overgrowth, fungal overgrowth. And sometimes it is isolated to the small intestines, or that's where the big problem's happening. Sometimes it's in the colon. But diagnosing it, no matter where it is, can be a little bit tough because there is no breath test to determine if someone has SIFO, because the only gas that those fungal species produce is carbon dioxide. We as humans obviously breathe out carbon dioxide. We can't distinguish what's from what. And there are stool tests that will do yeast cultures and microscopic counts of yeast. And so if there is an overgrowth of the yeast, at least in the colon, that might be a decent test to diagnose at least colon yeast growth. And that might mean they do have too much yeast high up in the small intestines as well. And so for diagnosis, let's put it this way, I don't test for fungal overgrowth as much as I test for SIBO, but you can definitely look for hallmarks again. And, prevalence, I would say SIBO, at least being the root cause behind someone's quote unquote IBS case, is higher than a fungal dysbiosis being the root cause. But a lot of times they happen together. And sometimes, depending on what SIBO treatment you give, it actually might make the fungal dysbiosis worse as well. So, you got to keep in mind, should I do a fungal treatment along with the SIBO treatment or just wait and see? But, some hallmarks for fungal overgrowth, of course.
For example, if you use the elemental diet, that tends to promote the growth of fungal because there's sugar in it.
Yeah, exactly. And another thing could be even some of the pharmaceutical antibiotics. Rifaximin, I'm not very worried about it causing a problem because it's not eradicating good bacteria in the large intestine where, fungal growth can start to take hold, is in the colon. But, those other antibiotics, neomycin, potentially metronidazole, amoxiclav, sulfatrim, they all could make the fungal growth worse as well. So, but elemental diet, yeah, you're right. I mean, that can be a problem as well. So, and there are some keto versions of elemental diet out there now. Without the glucose, which tastes even worse than the standard elemental diet. So most patients don't go for it anyways. But basically, looking for certain hallmarks as well. So what I see in practice, at least, and maybe you see the same thing, is that when someone has a chronic gastrointestinal fungal issue, is that it'll present systemically in a lot of ways as well. So maybe it's oral thrush, but maybe fungal scalp problems or recurrent fungal infections on the skin elsewhere. It doesn't always have to be scalp, or it doesn't always have to be athlete's foot. Or if they have, if it's a female patient and they get recurrent vaginal yeast infections, a lot of these things can stem from a fungal dysbiosis as the root to all these systemic issues. So if you have a patient with a lot of that history, maybe, consider that it might be stemming from the gut. And then, asking patients, specific reactions to things as well. So, the classic would be sugar and alcohol, because that would be the primary fuel source for the fungal species. And so what I'll ask patients is about sugar is that not just does it cause gastrointestinal symptoms, but, I'll ask questions such as, I usually just ask first, like, if you eat like a candy bar, does anything strange happen? And just let them answer without me leading them. But then if I need more kind of details, I'll ask, okay, if you ate that candy bar, would you feel like you almost had a drink or two, like an hour later, almost like the buzz feeling, or maybe not get the buzz feeling, but almost feel like you're getting a little bit of a hungover feeling a few hours later, or even the next morning. Same thing with alcohol. I would ask, are you very sensitive to alcohol? Like do you have one drink and feel like you had two or three? Or is it that you only have one drink, but the next day you feel like you had two or three or even more? And the big reason for those questions isn't just that they use as a fuel source, is that especially Candida species, one of their probably most harmful metabolite is acetaldehyde. And acetaldehyde is classified as a neurotoxin. And it's also carcinogenic. So heavy production of it over years is not very good for us. But that metabolite from fungal species definitely can cause things like brain fog, that hungover feeling, nausea, tachycardia, increased heart rate. And so if patients are getting those kind of strange reactions when they have high amounts of sugar or alcohol, I'll definitely start to suspect fungal growth, and then, possibly, include a fungal treatment.
So what's your favorite fungal treatments?
So once again, break it down to pharmaceutical and natural, because there's obviously pros and cons. One of the pharmaceutical agents that I do use is high-dose nystatin, and I'll get it, at least here in Canada, we can't get it in capsules anymore. It only comes in liquid with things like parabens in it and all that. So I don't prescribe that version of it. I get it compounded into capsules, and I do about 3 million units a day. So 1 million units 3 times a day. You can go up to 5 million units a day, but the higher you go, the higher chance of gastrointestinal symptoms. But that's one reason why I go with it, is that it's not really a dangerous medication by any means. It's non-absorbable. And so if it's going to give side effects, it's usually gastrointestinal side effects. And at 3 million units a day, most patients tolerate it just fine. And because it's non-absorbable, it can target the fungal species throughout the GI tract. So small intestines and large intestine. And so you don't have to worry about it being absorbed before it hits, let's say, colon growth. It's very effective. Nystatin, it's old school. It's been around for years, but it is still very effective at killing most Candida species by disrupting their cell membrane. So I do use that one quite often. I don't prescribe fluconazole or other azole antifungals that often. In some cases they are the magic bullet, but they do come with a higher list of potential side effects, some more contraindications with other medications, which could be dangerous depending on which medication the patient's on. Short-term use, they're not that bad, but if I know of docs that will you do 2, 3, 4, 5, 6 weeks of it, it's still at a pretty moderate dose, but then you're running into potential problems. And I do find good success with nystatin pharmaceutically, so I'll typically start with that. But naturally, there's some very good options as well. And they're all pretty much fatty acids, and a lot of them from coconut oil derived, but not all of them. So obviously, a lot of people know about caprylic acid. So caprylic acid and capric acid from coconut oil are definitely very good antifungals. Those acids don't only disrupt the cell membrane of the yeast, they also inhibit the hyphae formation of the yeast. So Candida species are, polymorphic. So they can go from a dormant unicellular form into a multicellular form. And it's the multicellular form that's the problem. And they can even produce little hyphae, these little legs that come off the cell body to be more invasive. Caprylic acid and capric acid can actually inhibit that, and it can also arrest the cell cycle of Candida when they replicate. So it doesn't just kill the Candida, it can actually inhibit their replication, efficacy. And so getting it from pure MCT oil is an option. You can get higher doses much easier. The benefit of doing like a caprylic acid supplement, like a magnesium caprylate or a calcium caprylate, is that when they combine it with the mineral, it will get further down the GI tract. So if you are worried about that, just the pure MCT oil version of it, which is easy to get the high dose, it may absorb too quick. That's the one issue. But then there's another fatty acid from coconut oil, which gets not as much attention. But
what's the dosage you use for caprylic acid?
So if I was doing, ideally, if you're doing MCT oil, I'd go up to 3 grams a day. 3 grams 2 to 3 times a day. Up to. Okay. So 1 to 3 grams, 2 to 3 times a day of pure MCT oil. Now, some patients don't do well with high amounts of fat for various reasons. So you got to be careful with that. But when it comes to like the acrylic acid supplements, the ones that can get a little bit further down, I typically don't do up to 3 grams 3 times a day. I'll do about maybe a gram, 1,000 milligrams 3 times a day. And so if that's a pure caprylic acid supplement, or if it's one that has other ingredients in it, so they might just be taking a bunch of pills compared to eating the oil. But up to tolerance too. So if they can go a little bit higher and the fatty acid is not causing any sort of stratorrhea or nausea or anything like that, I'll push it a little bit, especially if they're getting better. The other fatty acid from coconut oil, lauric acid, monolaurin is the supplement version of it. I'm a huge fan of monolaurin. And so there's a product, at least here in Canada, that's available called lauricidin. And it's monolaurin in a little tub. Monolaurin comes in these little like soft white pellets, and it comes with a scoop, and you just put the scoop of it in your mouth. You swallow it with water. You don't chew them or anything like that. It'll taste like soap. So just make sure to tell your patients not to do that. But monolaurin is very, very antifungal, well proven, like caprylic acid, and it also inhibits the actual replication efficacy of Candida species. The bonus of monolaurin, which caprylic acid doesn't have, is that monolaurin has also been shown to be very effective against gram-positive bacteria. It's not very effective against gram-negative. And the problem is with SIBO is most SIBO cases have gram-negative bacteria overgrowing. But in some SIBO cases, if it is gram-positive bacteria, monolaurin might actually help. So it might kind of cross that threshold. And antiviral as well. Monolaurin for viruses with that have a lipid membrane. Monolaurin does have antiviral capabilities against that as well.
And so a number of the antimicrobial herbs like berberine and oregano are known to have antifungal properties as well.
Yes. Yeah, that's exactly it. So there are some herbs too that can cross over from the SIBO side of things into fungal. And so a lot of times when you're prescribing a patient high dose herbs for their SIBO, you're actually treating maybe a fungal growth that's there too, and you don't even know it, but the patient's getting better. And so that is true. Allicin extract, Podarco Podarco is a really good antifungal herb and also can work in some SIBO cases as well. But when we're talking like specific for fungal, then these fatty acids is really, really where it's at. And there's another fatty acid from castor oil called 10-undecanoic acid. This has been around for decades. It was actually one of the original over-the-counter antifungal creams back in the 70s, had 10-undecanoic acid in it. And it's still to this day extremely antifungal. It's just kind of gone to the wayside in popularity, and you can still get it in supplement form. Thorne still makes it. They have a funny name for the product, but it's called Formula SF722. But that's their 10-undecanoic acid formula. It comes in little soft gels. You got to take a high dose of it. 4 soft gels 3 times a day is what I would dose it at. But 10-undecanoic acid, it can directly kill the yeast, but what it's really, really good at is inhibiting the yeast from replicating, inhibiting the yeast from wanting to multiply. And so when you treat fungal species...
Now castor oil is pretty toxic, right?
Oh, yeah. Don't drink castor oil. No, yeah. So let's make it clear that. So this is a fatty acid from castor oil. This is totally safe to take internally. Right. But yeah, don't drink castor oil, everyone.
Isn't that where they get ricin from, I think?
Yeah, it's from... Is it from castor beans? I don't know. I can't remember. I think so. Something like that. Yeah. So yeah, don't drink castor oil. But the supplement 10-undecanoic acid, that's okay to take. And it is very, very effective at inhibiting yeast from being opportunistic. And that is the big difference between treating fungal overgrowth and SIBO, is that yes, some of the bacterial overgrowing SIBO could be opportunistic, especially some of those hydrogen sulfide dysbiotic bacteria. But majority of bacterial overgrowing in a SIBO case are not opportunistic. Fungal species are totally different. These Candida species are very opportunistic. They wait for a chance to replicate and take over. So one thing they can do when you come at them with artillery, and I see this mistake a lot of practitioners, is they'll just throw a bunch of nystatin at it or a bunch of whatever, caprylic acid at it. But the problem is the Candida, when you do that, if they're already in a stronghold, they can start to multiply faster in the presence of you trying to hit them with artillery. So what I like to do with a lot of these yeast cases, I'll put them on things like 10-undecanoic acid, or one reason why I use the monolaurin as well, or even caprylic acid, is that a lot of these natural agents don't just kill the yeast, they inhibit their ability to be opportunistic. They inhibit their ability to replicate quickly. So if you come at them with that aspect, you're probably going to have more success. So even though I do prescribe nystatin very often, I'll typically still give 10-undecanoic acid with it or monolaurin with it, so we can kind of hit it from multiple viewpoints.
Cool. This has been a great discussion, Dr. Khangura. What any final thoughts, and how can practitioners and listeners and viewers get a hold of you? And you have a great course for practitioners available.
Yeah. So like you mentioned at the beginning of the chat, I'm up in Victoria, BC, Canada. So, and because I'm doing a lot more stuff in the States, I've been having a lot of US patients wanting to book in. Unfortunately, I can't take any US patients. So still have to keep that to Canadian patients. But for any US practitioners that are looking for a comprehensive course in SIBO and just dysbiosis in general, my latest course is called Beyond Superseding SIBO. I've had a series of them over the years, and my latest one is still up for registration, and the website is supersedingsibo.ca, and seeding is SEDING, not 2 E's. And so it's about a 6-hour course, very comprehensive on SIBO and other dysbiosis, including some fungal. Next year, I'm hoping by spring 2021, I will have an updated version of this course with more specifics on certain areas. Because obviously, as time goes by, there's more to learn about and more to teach about. But this would be my most comprehensive course at this point. But otherwise, any closing comments? The one thing I'd like to mention is that and I understand where a lot of practitioners are coming from, is that SIBO, especially SIBO, seems almost like a fad diagnosis in the last few years. And a lot of practitioners are kind of starting to scoff at it because of that, saying that, oh, it's just, it's the new thing. It's the new flavor of, for diagnosis of IBS and all that. And the one thing I will tell practitioners that maybe think that's true is that give it a chance with your patients, because if you have not gone down the road of SIBO with most of your quote unquote IBS patients, and you are looking at your practice and wondering why just cutting out wheat hasn't helped them, just cutting out dairy hasn't helped them, giving them a healthier, more fibrous diet has made them worse, but you just don't have any answers for it, definitely start looking into SIBO specifically as a diagnosis. It's not an end-all be-all by any means. For a lot of patients, it's just part of the problem. I talked to Dr. Ruscio about practitioners really need to be careful of not getting into SIBO tunnel vision. Once you get that SIBO diagnosis, a lot of us just kind of look at that and be like, we got to tackle this, and you're missing something else. But for the practitioners out there that don't even consider SIBO, I really do recommend starting to look into it more, because for a lot of patients, it really is the very, very specific root cause. And these patients, we talked about the stubborn cases, but some cases will resolve in 2 to 4 weeks. And we're talking 10, 20 years IBS gone in 2 to 4 weeks of treatment. And if that's what the patient needs, that's what they need. So really just putting it all together, that's the way I look at it. And that's what all of us, integrative and, functional, whether naturopathic doctors or medical doctors need to do, is put it all together from all angles.
Excellent. Thank you.
Mm-hmm. Yeah, no problem at all.